Usually when we talk about a medical diagnosis, there is this expectation of precision. It feels kind of like engineering.
Right. It's very binary. Like the bone is broken or it isn't. The boundary is
Yeah.
clear.
You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, well, there it is. But then you look at something as ubiquitous as diabetes, and suddenly that x-ray machine is broken.
Yeah, completely broken.
We are looking at a diagnostic landscape that is incredibly murky, mostly because we try to diagnose this massive, complex disease using just a single number.
Which is really the core reason we are doing this deep dive. For you listening, especially if you're a nursing student grappling with the realities of diabetes mellitus, or just a curious learner, we really need to look past those tidy diagnostic numbers.
So they can be super misleading, right?
Absolutely. Our focus today is unraveling the actual pathophysiology. We want to understand the profound biological differences between type 1 and type 2 diabetes.
So, okay, let's unpack this. Currently, the American Diabetes Association, the ADA, diagnoses diabetes using strict lab thresholds. Like they look for a fasting plasma glucose of 126 milligrams per deciliter or higher.
Right, or an A1C of 6.5% or higher.
Yeah. But there is a fundamental flaw here. You could have two patients standing right in front of you. They both just got their lab results back, and they both hit the exact same A1C of 8.2%. From the number alone, they have the exact same disease.
But clinically, they arrived at that 8.2% through completely different, almost opposite biological mechanisms. Diabetes mellitus isn't actually a single disease.
Wait, really? It's not one disease?
No, not at all. It is a broad group of metabolic diseases that just happen to share one final symptom, which is chronic hyperglycemia. That just means persistently elevated blood glucose.
So because the medical field historically only looked at that final symptom, they just slapped one overarching name on it.
Exactly. To really understand why we rely so heavily on the end result, we actually have to look at how humanity first discovered this disease. This takes us way back, thousands of years before anyone could look inside a pancreas.
Oh, this history is wild. We are talking about the year 1550 BCE. The Ebers Papyrus in Egypt describes a condition characterized by just relentless excessive urination.
Yeah, and the terminology evolved much later. Around the 2nd century CE, a Greek physician named Aristeas of Cappadocia observed patients who were desperately thirsty. They were seemingly wasting away as fluid just passed straight through their bodies.
Which is horrifying.
It is. He coined the term diabanon, a Greek word that means to pass through, as if through a siphon.
It paints a very vivid and tragic picture of the end stages of the disease before modern medicine. The body is desperately trying to flush out this excess glucose it can't process, and it pulls massive amounts of water with it.
Right, the kidneys are just overwhelmed.
And for over 1,000 years, physicians were just trying to figure out what was happening using observation, which led to some fairly gross diagnostic methods.
I know exactly what you're going to say.
In the 17th century, doctors were literally tasting their patients' urine to see if it was sweet.
Yeah, literal taste tests. So in 1675, an English physician named Thomas Willis officially added the Latin word mellitus, which translates to honey sweet.
Just to differentiate it, right?
Precisely. The medical community needed a way to distinguish this sweet urine disease from another condition called diabetes insipidus. That one involves very dilute, non-sweet urine caused by a completely different pituitary hormone issue.
Wow, that was the absolute limit of diagnostics back then. You just observed the output.
Yep. The ability to actually look inside the body and see the mechanics came in a very tight cluster of discoveries in the 19th and 20th centuries.
Like Paul Langerhans, right?
Yes. In 1869, this 22-year-old German medical student, Paul Langerhans, was looking at pancreatic tissue under a microscope. He noticed these unusual clusters of cells scattered throughout the organ.
He had no idea what they did he?
None at all. But they were later named the islets of Langerhans in his honor. Then 20 years after that, in 1889, two physiologists, Oskar Minkowski and Joseph von Mering, were actually studying fat digestion.
Okay, so not even diabetes.
Right. To figure out the pancreas's role, they surgically removed the organ from a dog. Weeks later, a lab assistant noticed that flies were suddenly swarming the dog's urine.
Because it was absolutely saturated with sugar.
Exactly. By taking the pancreas out, they proved for the very first time that this specific organ produces a substance essential for controlling blood sugar.
Which sets the stage for arguably the most dramatic medical breakthrough of the 20th century. In the early 1920s, at the University of Toronto, surgeon Frederick Banting and medical student Charles Best finally isolated a pancreatic extract that lowered blood sugar in diabetic dogs.
And then a biochemist named James Collip purified it for human use.
Mm.
On January 11th, 1922, everything changed.
They had a 14-year-old patient, Leonard Thompson, who was actively dying of type 1 diabetes at Toronto General Hospital. Before insulin, a type 1 diagnosis was a guaranteed death sentence, usually within a year or two.
Physicians tried to buy these patients time with strict starvation diets, which reduced sugar intake but left the children skeletally thin. It was incredibly grim.
The first injection they gave Leonard Thompson was actually too impure. But a couple of weeks later, they gave her a purified batch. His blood sugar dropped, and he began to recover.
Insulin turned an inevitably fatal disease into a manageable chronic one almost overnight. It's an amazing story. Banting actually split his Nobel Prize money with Best because he was so furious the Nobel Committee excluded the medical student.
That's some great medical drama right there. But as incredible as the discovery of insulin was, I think it created a massive clinical blind spot.
Oh, it absolutely did. Insulin was a miracle cure, but it treated the symptom of a failing system. Because it fixed the end result, the high blood sugar, it heavily masked the fact that there are two very different ways that system breaks down in the first place.
Which brings us to the actual starting lines of these conditions, the first principles. Let's start with type 1 diabetes, which is fundamentally an autoimmune fire.
That's a great way to put it. In type 1, the immune system, primarily the T lymphocytes, goes rogue. It mistakenly identifies the insulin-producing beta cells inside those pancreatic islets as foreign invaders, and it systematically destroys them.
When a patient gets tested for this, they often see an alphabet soup of autoantibodies on their lab chart. Things like GAD65, IA2, or ZNT8. What are those actually doing in the body?
Well, those acronyms represent the specific targets the immune system is attacking. GAD65, for example, stands for glutamic acid decarboxylase.
Say that 5 times fast.
Right. It's basically an enzyme that naturally exists inside the beta cells and is essential for them to function. But in a type 1 patient, the immune system's threat detection software glitches. It tags GAD65 as a hostile pathogen.
So the presence of these autoantibodies in the blood is basically the smoke billowing up from that autoimmune fire.
Exactly.
And there is a genetic blueprint for this glitch, right? The HLA genes.
Yes, specifically the human leukocyte antigen genes like HLA-DR3 and HLA-DR4. These genes code for the major histocompatibility complex. That is basically the immune system's threat display window.
So if you have these specific variants, your immune system is highly sensitive and prone to friendly fire.
Yeah, but genetics alone aren't enough to start the destruction. Something in the environment, very likely a viral infection like an enterovirus, appears to act as the trigger. It tips a genetically susceptible person into full-blown autoimmunity.
The terrifying part is the silent progression. By the time a patient actually starts showing symptoms like intense thirst, 80 to 90% of their beta cell mass is typically already gone.
It's staggering.
I've often heard the analogy of a factory making keys for a lock, but that feels a bit passive to me. To visualize what's actually happening at the cellular level, I like to think of a massive city transit system.
Oh, I like that.
Yeah, glucose is the passengers, and insulin is the train fleet that moves them out of the bloodstream and into the cells. Type 1 diabetes is like the city's own military bombing the train yard. It's an absolute deficiency. It does not matter what your diet is or how much you exercise, the trains are gone.
That captures the absolute nature of the deficiency perfectly. Type 2 diabetes, however, starts from the complete opposite direction. It begins with insulin resistance.
Okay, so how does that look in the transit analogy?
Well, the transit system is fully operational and the trains are running.
Yeah.
But the stations, the peripheral tissues like your muscle, liver, and fat, refuse to open their doors to let the glucose passengers inside.
The stations are refusing entry because of ectopic fat, right? But
Yeah.
I always hear that term thrown around without much explanation. How does fat actually stop glucose from getting into a cell?
To understand that, we have to look at the Randle cycle. Sometimes it's called the glucose fatty acid cycle, which was described in 1963. Ectopic fat refers to lipid storage in places it shouldn't be, primarily inside the liver and muscle cells.
So they're just getting stuffed with fat.
Right. When these cells are overwhelmed by excess circulating free fatty acids, they start metabolizing the fat for energy instead of glucose.
Which makes sense on a survival level, I guess, but what does it do to the insulin signaling?
Burning all that fat generates high levels of intracellular metabolic byproducts, specifically things like diacylglycerol. These byproducts are physically disruptive. They interfere with the insulin receptor substrate pathways.
Wait, so they just block the signal?
Pretty much. Insulin arrives at the cell membrane and binds to the receptor, swiping its badge to open the door. But the electronic signal gets scrambled by these fat byproducts. The door stays shut.
And the glucose passengers just build up in the bloodstream. So what does the pancreas do when it senses this massive crowd of glucose going nowhere?
It compensates through brute force. The beta cells pump out massive amounts of insulin to try and force the signal through. This state is called hyperinsulinemia.
That sounds exhausting.
It is. For a few years, this works. The blood sugar stays roughly normal because the pancreas is working intense overtime.
But the beta cells can't pull overtime forever. The cellular stress must be immense.
The stress is terminal, honestly. Over decades, these overworked beta cells suffer from literal chemical damage caused by chronic exposure to high glucose and high lipids. We call this glucotoxicity and lipotoxicity.
So they basically poison themselves trying to keep up.
Exactly. The oxidative stress overwhelms the cell's internal machinery until they literally undergo apoptosis-programmed cell death. The insulin secretion eventually crashes, falling far behind the massive demand. And that is when the clinical hyperglycemia emerges.
So type 2 is a relative insulin deficiency layered on top of severe resistance.
Exactly right.
This mechanical difference isn't just theory. It dictates exactly how these diseases show up in the real world. I was looking at the concordance rates for identical twins, and the split between the two diseases is fascinating.
Oh, the twin data isolates the genetic variable perfectly. If one identical twin develops type 1 diabetes, the co-twin's risk of developing it is only about 30 to 50%.
Which proves they have the exact same genetic threat detection glitch, but an external environmental trigger is absolutely required to ignite the autoimmune fire.
Yep, spot on. Contrast that with type 2 diabetes. If one identical twin develops type 2, the co-twin's concordance is commonly cited in the 70 to 90% range.
Wow, that is a massive jump.
It really is. This reflects just how heavily type 2 is driven by a shared genetic architecture for fat storage, combined with shared lifestyle and environmental factors.
This biological difference becomes a literal matter of life and death in the ER too. For the nursing students listening, the emergency presentations for these two diseases look very different because of the underlying chemistry. Let's talk about DKA versus HHS.
Good idea. DKA stands for diabetic ketoacidosis, and it is the hallmark emergency of type 1 diabetes. Because a type 1 patient has virtually zero circulating insulin, their body thinks it's starving.
Even if their blood sugar is sky high.
Yeah, because the glucose can't get into the cells. Without insulin to act as a braking system, a specific enzyme in the fat cells called hormone-sensitive lipase goes into overdrive. The fat cells release massive amounts of free fatty acids into the blood.
And the liver tries to process all that fat, right?
The liver takes those fatty acids and rapidly converts them into ketone bodies for emergency fuel. The problem is that ketone bodies are highly acidic.
So the blood turns acidic.
Right. They flood the bloodstream, overwhelming the body's natural buffering systems, and the blood pH drops dangerously low. This acidosis disrupts enzyme functions body-wide, creating a life-threatening crisis. Sometimes DKA is the very event that reveals a type 1 diagnosis in a previously healthy child.
That is so scary. But a type 2 emergency plays out entirely differently. They usually don't go into DKA because they still have that struggling train yard pumping out a tiny bit of insulin.
That residual insulin is the key difference. A type 2 patient might not have enough insulin to control their blood sugar, which can skyrocket catastrophically to 600, 800, or even over 1,000 milligrams per deciliter.
Oh my gosh. 1,000.
Yeah, it can get that high.
Right.
But that tiny trickle of insulin is usually enough to keep that hormone-sensitive lipase in check, so they don't experience the massive fat breakdown, and they don't produce significant ketones.
Instead, they present with HHS, hyperosmolar hyperglycemic state. The blood sugar is so high, it essentially turns the blood into a thick syrup.
Yeah, syrup is a good way to picture it. This hyperosmolarity pulls water directly out of the brain and surrounding tissues, leading to severe dehydration and altered mental status, but without the extreme acid buildup.
The underlying mechanism completely dictates the clinical reality you see in the trauma bay. If the mechanics dictate entirely different emergencies, the historical labels of insulin-dependent and non-insulin-dependent diabetes must have been incredibly frustrating for clinicians.
They were deeply misleading. Until 1997, the World Health Organization and the ADA classified the disease based on the treatment you were receiving.
Which tells you nothing about what's actually wrong with the patient.
Exactly. Because type 2 is a progressive disease driven by glucotoxicity, plenty of quote-unquote non-insulin dependent patients eventually require insulin therapy as their beta cells undergo apoptosis. The labels said nothing about the actual disease process.
So in 1997, the ADA's expert committee formally anchored the categories to the etiology. Type 1 became the label for autoimmune destruction, and type 2 became the label for progressive insulin resistance.
And this understanding of progression really crystallized with two massive clinical trials in the 1990s, the DCCT for type 1 and the UKPDS for type 2. Both trials prove that keeping blood sugar as close to normal as possible dramatically reduced microvascular complications.
Okay, but how does high blood sugar actually break a blood vessel in the eyes or the kidneys?
It comes down to a process called glycation. When glucose levels are chronically high, the excess sugar molecules literally stick to the proteins and lipids that make up the walls of your blood vessels.
Wait, they just stick to them?
Yeah, this creates what are called advanced glycation end products, or AGEs.
That sounds like rust building up inside a pipe.
It functions very much like that. These AGEs stiffen the vessel walls, promotes systemic inflammation, and cause the tiny capillaries in the retina of the eye, the filtering units of the kidneys, and the linings of the nerves to physically thicken and leak. The DCCT and UKPDS trials prove that the hyperglycemia itself is what drives this structural damage.
Okay, so we've established this very logical, neat two-bucket model. Type 1 is the autoimmune destruction. Type 2 is the fat-induced insulin resistance.
Right.
But here's where we get to the cutting edge, because nature hates neat boxes, and modern science is actively taking a sledgehammer to this binary.
Oh, yeah. The two-bucket model is now openly debated inside endocrinology. The major turning point was a 2018 Swedish study published by Almqvist and colleagues in the Lancet Diabetes and Endocrinology.
They didn't just look at a few basic labs, did they?
No, they applied complex cluster analysis to massive amounts of metabolic and genetic data from nearly 9,000 newly diagnosed diabetes patients.
And they didn't find two groups. They found 5 distinct clusters of the disease.
5 unique metabolic profiles. They identified a severe autoimmune cluster, which maps to our classic type 1, but then they broke the type 2 bucket into 4 separate diseases.
Wow, 4.
Yeah. They found a severe insulin-deficient cluster where patients look like they have type 2 but produce very little insulin and have a massive risk of retinopathy. They found a severe insulin-resistant cluster where patients produce plenty of insulin but have an incredibly high risk of kidney disease. And finally, they identified a mild obesity-related cluster and a mild age-related cluster.
The implication there is staggering. It means treating every quote-unquote type 2 patient the same is physiologically backward. A severe insulin-deficient patient needs a completely different pharmaceutical strategy than a severe insulin-resistant one.
Absolutely. The textbook binary is largely a simplification we've kept around for teaching and medical billing convenience. We can actually see this blurring of the lines in clinical practice right now with something called LADA.
LABA stands for latent autoimmune diabetes in adults. Some clinicians informally refer to it as type 1.5, right?
Yes. These patients test positive for the exact same autoantibodies as type 1, especially GAD65.
Yeah.
The autoimmune fire is burning, but it's burning in slow motion.
And because they are adults and they don't immediately go into DKA, they get misdiagnosed as having type 2.
This is a critical failure mode that nurses and clinicians must watch for. A lean adult comes in with elevated blood sugar. The clinician assumes it's type 2 based on age, puts them on an oral medication like metformin, and sends them home.
But metformin primarily reduces glucose production in the liver. It does absolutely nothing to stop the immune system from destroying the beta cells.
Right. Eventually, the destruction completes, and the patient absolutely requires insulin. Misdiagnosing LEA delays necessary therapy and causes immense metabolic stress.
That actually touches on one of the biggest misconceptions we need to clear up. The stereotype that type 2 diabetes only happens to overweight individuals.
Oh, that is a huge myth.
Lean people absolutely develop type 2 diabetes based on their specific genetic architecture for fat storage. If your body has a very low capacity to safely store fat in subcutaneous tissue, even a small amount of weight gain can spill over as ectopic fat into the liver and trigger the Randle cycle.
The epidemiology forces us to confront these stereotypes constantly. We saw this historically when pediatric type 2 diabetes became so common that the medical community had to retire the old name adult-onset diabetes.
Because kids were getting it.
Exactly. And we must also confront the myth that type 1 is caused by a poor diet. Type 1 has zero to do with sugar consumption. It is an autoimmune genetic roll of the dice, and the stigma around it causes needless guilt for families.
Which brings up a fascinating current debate in the medical community, the concept of reversing type 2 diabetes. We hear this a lot with the rise of bariatric surgery and extreme low-calorie diets, like those studied in the UK's DIRECT trial.
Yes, the direct trial was groundbreaking.
They showed that intensive weight loss can effectively clear out that ectopic fat infiltrating the liver and pancreas, restoring normal glucose control in a substantial fraction of patients.
It is a phenomenal therapeutic advancement, demonstrating just how mechanically driven insulin resistance is. But the ADA strongly prefers the term remission over cure or reversal.
Because the genetic susceptibility to the Randall cycle hasn't gone anywhere.
Precisely. The genetic architecture remains. The beta cell capacity and the underlying insulin resistance will rapidly redeteriorate if the ectopic fat returns, or simply as a consequence of aging. Remission acknowledges that the environmental trigger has been removed, but the underlying biology requires lifelong vigilance.
So what does this all mean for you listening? Why did we just spend 20 minutes dissecting the Randall cycle, autoantibodies, and identical twin studies?
Because understanding the mechanism is the absolute foundation of clinical relevance. If you are a nurse and you treat a type 1 patient's DKA the way you would manage a type 2 patient's HHS, or if you assume a 35-year-old lean adult can't possibly have LADA, that misunderstanding can be fatal.
Furthermore, understanding these pathways is the only way to make sense of the modern pharmaceutical revolution we are seeing. Take the blockbuster GLP-1 receptor agonists, like semaglutide.
Right. They work by mimicking incretin hormones.
Yeah, which naturally amplify the pancreas's ability to print those insulin badges in response to food. Or the SGLT2 inhibitors, which bypass the insulin system entirely and just force the kidneys to dump the excess glucose cargo directly into the urine. You cannot understand the treatments without understanding the biological machinery they're acting upon.
The pathophysiology underpins every treatment algorithm, every emergency response protocol, and how you educate your patients to take control of their own health.
I want to leave you with a final thought to mull over. Back in 1997, the medical community redefined this disease overnight. They dropped a diagnostic threshold from 140 down to 126 milligrams per deciliter, and they retired the confusing IDDM and NIDDM labels.
It was a massive shift.
Given the 2018 discovery of the 5 distinct genetic and metabolic clusters we discussed today, how long will it be before the labels type 1 and type 2 themselves become historical relics?
It's a great question.
We are on the verge of completely changing how we diagnose and treat this 3,000-year-old disease tomorrow. The next time you look at an A1C number, remember, it is just a number. It's the biological mechanism behind it that tells the true story.